Hi, I'm Dr. Hess and I'm an ophthalmologist. Ophthalmoscopy, also known as fundoscopy, is the examination of the back of the eye or the ocular fundus. What's special about fundoscopy is that it's the only physical exam where blood vessels and nerves can be directly and non-invasively visualized. As a result, good fundoscopy can detect both ocular and systemic disease, and it's a valuable clinical skill to master with lots of practice. In this video, we'll cover the red reflex and the anterior segment exam before moving on to the 4-step technique for fundoscopy, which consists of assessing the retinal blood vessels, the optic disc, the macula, and the retinal periphery. As usual, we'll wrap up with some tips and tricks at the end, so let's begin. After performing hand hygiene, introduce yourself to the patient and get their verbal consent to perform the exam. Sit the patient at a comfortable height and dim the room lights. For the purposes of this video, we'll leave the room lights on. If the patient wears glasses, ask them to remove these. You can remove yours too, unless you have a high prescription, in which case it's better to leave them on. Next, you want to dilate the patient's pupils with mydriatic drops, because fundoscopy through undilated pupils can be difficult. A short-acting mydriatic drop, such as tropicamide 0.5% or 1%, is ideal for this. Prior to dilation, examine the pupil reflexes as well as visual acuity and visual fields, because you won't be able to do this properly once the pupils are dilated. Start by giving the patient a specific target in the distance located straight ahead of them. Stay out of the patient's line of sight by standing about 15 degrees to the side. This keeps their eye still and prevents any pupil constriction from the accommodation reflex. To examine the patient's right eye, use your right eye with the ophthalmoscope in your right hand. In other words, line up their right with your right. Similarly, line up their left with your left for their left eye. Stand or sit at arm's length with the ophthalmoscope at the patient's eye level turned on with the appropriate aperture and filter setting. Prior to fundoscopy, assess the red reflex and examine the anterior segment or front part of the eye. The red reflex is assessed at arm's length by aiming the light beam into each pupil and observing the reflected glow, which should be a fairly symmetric orange-red color. An absent or dull red reflex indicates an opacity somewhere in the ocular media, which may be in the cornea, the anterior chamber, the lens, or the vitreous. Beware an absent or dull red reflex in a newborn baby or infant. This requires an urgent referral to ophthalmology because it may be due to a rare but serious intraocular tumor known as retinoblastoma. To examine the anterior segment, move into about 15 centimeters from the patient, still at a 15-degree angle, and gently place your offhand on the patient's forehead for stability. Examine the anterior part of the eye for things like conjunctival injection and corneal opacities. You'll need to dial up a plus lens to around 10 diopters to get a clear view here. Now dial the lens back to 0 to perform the 4-step fundus examination. Looking directly into the pupil, you'll see an orange-red color first, which is the retina. Now move around, adjusting the lens power until some feature comes into focus, and often this is a retinal blood vessel. So retinal blood vessels consist of paired arteries and veins, with the veins being wider in caliber and darker in color. Follow the course of a pair of vessels to get familiar with what normal looks like, and look for abnormalities such as vessel tortuosity and AV nipping, seen in systemic hypertension, and venous beading, which is seen in severe diabetic retinopathy. Also look for perivascular abnormalities such as cotton wool spots and retinal hemorrhages, which are seen in conditions that include diabetic retinopathy and retinal vein occlusions. Examine all 4 of the retinal vascular arcades, which emanate from the optic disc in the infratemporal, infranasal, supranasal, and supratemporal quadrants. As you do this, track the vessels towards the optic nerve, which is located in the nasal aspect of the fundus. So remember, the nerve is nasal. Another clue is that any V shapes created by vessels point towards the optic disc. Once you find the optic disc, it will fill up most of the 10-degree view of the ophthalmoscope. Assess the 3 C's of the optic disc, which are the color, the cup, and the contour. The normal color of the optic disc is yellow. It becomes pale in cases of ischemic optic neuropathy or giant cell arteritis, or it becomes a reddish color in a hyperemic disc from optic disc swelling. The contour or margins of the optic disc should be well defined. If the contour is blurred or fuzzy, this can be due to optic disc swelling. And if this is present in both eyes, this is papilloedema from raised intracranial pressure or malignant hypertension and requires urgent attention. The central pale portion of the optic disc is called the optic cup, and the normal ratio of diameters between the optic cup and the optic disc is between 0.3 to 0.5. If the ratio is above this, or if there's a lot of asymmetry between the two discs, then the patient needs to be evaluated for possible glaucoma. In patients with diabetes, also check the optic disc for neovascularisation, which looks like very fine, frilly vessels, sometimes in a small net. Now examine the macula by moving temporally away from the optic disc, or by asking the patient to look directly into the light, which automatically shows you their macula. The normal macula has a dark orange or reddish appearance. Within this, look for yellow deposits known as Drusen, which are seen in age-related macular degeneration. In patients with diabetes, look for hemorrhages and hard exudates. And in patients with sudden painless loss of vision, look for a pale whitish macula with a very red center known as a cherry red spot, which is caused by a retinal artery occlusion. Finally, examine the retinal periphery by asking the patient to look up, down, left and right, looking for abnormalities such as a pigmented ocular tumor or a retinal detachment. Now repeat the examination for the left eye, remembering to use your left hand and your left eye. Some tips and tricks for fundoscopy. First of all, remember that the normal fundus consists of a yellow optic nerve, red blood vessels, all on an orange background of the retina. Any findings outside these simple parameters, for example, yellow dots in the central macula, are worthy of further evaluation. As you see more fundi, you'll notice a lot of variations on these simple parameters, but they're a good starting point for beginners. The green filter, also known as the red free filter, is good for highlighting red structures, such as the outline of blood vessels, as well as microaneurysms, also known as dot hemorrhages, which might be otherwise difficult to detect in diabetic retinopathy. The bottom line with fundoscopy, meaning its most crucial use, boils down to its ability to detect life-threatening disease. And what we're talking about here is papilloedema, which, until proven otherwise, should be assumed to be due to raised intracranial pressure from a space-occupying lesion, a tumor in the brain. So by detecting papilloedema, the humble ophthalmoscope can prevent morbidity and even mortality in some patients. So to summarize, in this video we've covered the red reflex and the anterior segment exam, as well as the 4-step technique for fundoscopy, consisting of the retinal blood vessels, the optic disc, the macula and the retinal periphery. With lots of practice, good fundoscopy makes for a more well-rounded clinician or healthcare practitioner, and it can help detect both ocular and systemic illnesses simply by looking into your patient's eyes. Thanks for watching this video. For more eye videos, visit eyeballsmadeeasy.com.au, and if you have any questions, feel free to get in touch.